Good evening, good morning, depending on where you are in the world. I'm Tony Roche. I'm a consultant anesthetist at the University of Washington in Seattle. And I was asked to introduce Dr. Chris Terblanche, who is a fellow countryman of mine from South Africa. Although he didn't attend the right undergraduate university, went to the University of Cape Town. He would have done a lot better if he went to Stellenbosch. It still is my intense pleasure to introduce him. Despite the fact that I'm usually based in Seattle, I happen to be in Windhoek right now with some partners, and Chris is just about 7 or 8 hours drive away to the north. Chris is a remarkable human being, I would like to tell you. He has completed his undergraduate training in Cape Town, spent some years in Wales, in Swansea, where he did his specialist training in anesthesia and critical care. He's a person who in, 2019, 2018, uprooted his family and brought them all the way to the beautiful north of Namibia to be involved in something bigger than any one of us. He's an inspiring human being. He is intensely involved in training, in teaching, in clinical service. He's a passionate love for barbecue, which is probably one of his finer attributes. He taught me how to slaughter a goat last time I was up there in the north. But he's passionate about POCUS. He's passionate about, as I say, critical care anesthesia and just leaving the world a better place than he found it. And with that, Chris, I shall hand over to you and looking forward to hearing your talk.
Thank you very much, Professor Roach. Should I screen share now?
Yes, that would be great. And we can see your screen. That looks great.
Okay. So are we waiting for any stragglers, or should I just crack on for time is...
I would probably crack on.
Okay. Can you hear me okay?
Yes, you sound great.
Okay. So thank you very much for this opportunity and privilege of being able to address the learned community of POCUS. So I've entitled my talk, Can We Replace Our Stethoscopes with Ultrasounds in Oshakati, Namibia? So just to get out the way, the views are all my own. The equipment we have has been donated. So there's no conflict of interest, I can say. So what are the learning objectives for the next half an hour or so? I'm hoping to leave lots of time for questions and comments and some collaboration. So I'm going to just, kick off with some definitions as usual. We'll talk a bit about stethoscopes versus ultrasound. I'll talk briefly just to put in context my own story and then Oshakati's story in terms of where we are with ultrasound and what we are doing currently with POCUS. We'll talk a bit about what is available. I'm going to talk very briefly about some ancillary equipment, some of which we have or some of which we don't. Talk very briefly about training and accreditation, which is something I'm quite passionate about. And then I'll answer the question. So let's go for it. I'm happy if people want to put their hand up or ask questions as we go. So what is a stethoscope? So I had to go to vocabulary.com. And for the Greek scholars in the audience, stethos is chest or breast, and scope an instrument for seeing. And some people have argued that actually a stethoscope is not seeing anything, it's hearing, and that sonar is the true stethoscope, which is probably a very good observation. So for those historian buffs, I'm not sure how you pronounce his name, Laennec. I think he was French, over 200 years ago invented the stethoscope, and it's been a firm, entrenched part of medicine ever since. Whether it should be still that firmly entrenched is something we will be discussing. So what about POCUS? It's an acronym, as you know, for point of care ultrasound. And if you try and look up papers about POCUS, everyone gives their own definition. You look online, there's lots of different definitions for what POCUS is or isn't. The definition oh, sorry, that I liked quite, that sums it up quite nicely. I've got all the references at the end if anyone wants to get any of them. So it's ultrasound brought to the patient and performed in real time by a treating clinician. I think that for me sums it up, and I think many in the audience will agree with that. So what about the stethoscope? Is it any good? So again, looking at some science, people have looked at sensitivity and specificity. So this paper, we're looking specifically at lung auscultation, so breath sounds. And as you can see, it's not very good. For the trainees in the audience, just to define a bit what sensitivity and specificity is. So sensitivity is a test's ability to identify an individual with the disease as being positive. So a highly sensitive test has few false negative results and few cases of the disease are missed. So if you've got a serious condition, you really want a very sensitive test so that you don't miss anyone with the disease. And obviously, as you can see, a sensitivity of 37% is not very good. Am I supposed to be admitting people, or let me click admit?
No,
Then
we can do it.
Okay, great. So the specificity of a test is its ability to designate an individual who does not have a disease as negative. So this paper, I just wanted to quote a couple of things that they said as their conclusion, having looked at quite a lot of papers. So they've said auscultation can be considered not clinically useful in making a diagnosis in most circumstances. And the question is then, why are we still doing it so much? And they suggested that only in clinical situations in resource-limited areas, which is where I'm working, with a high prevalence of disease and in experienced hands, the stethoscope has some clinical relevance. So there's no standard nomenclature. So if you're looking just at lung sounds, which is a bit of an issue, I remember when I came to Namibia, I was working with an intensivist from Cuba, and some of his nomenclature for some things he heard with the stethoscope were different to mine, and that is an issue. So what about POCUS? So this paper, they again looked at lung ultrasound specifically, and they found that point-of-care ultrasound had a sensitivity of 95% and a specificity of 94%. So ultrasound performed much better than the results that I showed you for a stethoscope for the same thing. So this is just a bit more detail from that paper. And it seems in terms of sensitivity, looking for or listening for a hemopneumothorax in the context of trauma had the highest sensitivity, which is kind of what you would expect. So having painted a bit of a background about, how good is sonar, how good is the stethoscope, let me just go through a little bit my own story just to put things into perspective for you. So as Tony said, I qualified at UCT, which is, not far from Stellenbosch, but we won't go into that. I then did my postgraduate training in the UK and ended up in Swansea. So I trained to be an anaesthetist, I trained to be an intensivist, and then I started with undergraduate medical education. Swansea has a graduate entry medical school. And I kind of said to myself, well, I've studied everything else I do. Why didn't I study education? So I ended up doing a master's in education, which I would highly recommend for anyone that is passionate about teaching. It gives you a whole new perspective on what you're doing. So I remember as an intern at Krutskia in 1993, I know some of you weren't born then, learning a landmark technique for putting a CVC in. I remember putting a subclavian in a lady with subacute bowel obstruction in a surgical ward. It was my first, I sort of saw one I did one and probably then taught one. I am on call. I'm just going to answer the call 1 sec. Hello? Hello?
Hi, everyone. While Chris is answering his call, just wanted to reiterate one thing that Chris said, which is that he is a part of this collaborative to sort of find other collaborations amongst us. So I think a lot of us here are here for that reason. So part of the goal is that we all have POCUS collaborations here. So if anyone wants to have conversations about POCUS or work with other people within the group, please feel free to contact Sarah at any point in time, and we'll connect people to each other. Thank you.
Yeah. Okay. Sorry about that. Unfortunately, I'm the only ICU consultant, so I can't turn my phone off. So I remember when I was still in the UK, 1999, seeing this editorial in the BJA about using sonar for CVC insertion. And it was entitled, "In the Country of the Blind, the One-Eyed Man is King." And I would definitely recommend it to you. I have it if anyone is unable to access it. I think it is available online for free. And essentially what they're saying, if you can use sonar for inserting central lines, it's better in terms of complications, even though it was quite a long time ago that this editorial was written. At the time, it wasn't commonplace in the UK to use sonar. It's now become almost mandatory, I would say, certainly for elective cases, to use sonar. So continuing on, I did a list for an orthopedic surgeon every alternate week when I was in the UK. When I started that, it was 2005. We didn't have ultrasonography available in the hospital where I was working in the UK. So we were using nerve stimulators for doing blocks. We did have quite a few people who were quite enthusiastic in Swansea about using sonar and training people for using sonar for nerve blocks. And that became very popular. And then we started using sonar also for central line insertion, but it took a bit longer for ICU to catch up compared to the colleagues in theaters, anesthesia. And then around 2018, one of my colleagues started as a specialist or consultant in ICU, and he started getting involved with one of the cardiologists to teach cardiac POCUS on the ICU. And they started a program where registrars that were rotating through the ICU would start learning to do cardiac POCUS. Unfortunately, I had my hands in too many other things and I didn't get involved, and it's probably now something I regret. But, you know, sometimes you can't do everything at the same time. So then I came to Namibia, as Tony said, beginning of 2019, lock, stock, and barrel, as they say. So what is Oshakati's story? So yeah, I came in 2019. When I came, there were no registrars here in the north. I came straight to the north. I sort of bypassed Windhoek, the capital, The MEd in anesthesia through the University of Namibia started in Windhoek 2018, and I was involved a bit in some of curriculum writing and some teaching. But the first cohort in Oshakati only started in 2020. And at the time when I started here, no one was really using ultrasound in anesthesia, either for inserting lines or for blocks. And both in ICU and in theater, well, I discovered there was one in theater in a box that no one had used. We had a WED, and I can hear you saying, what's a WED? Well, that's a WED. It's a curvilinear probe. It gives a very small picture in the middle of the screen. For central line insertion and blocks, it's useless. You can use it for maybe looking at cardiac and organs, but people weren't really using it at all. So with the MEd starting in Windhoek, there were ultrasounds available, some donated, I think some were bought by the ministry. And they were being used by trainees, anesthetic trainees. As I say, our first registrar started here in 2020. The WED was the only thing we had, so people weren't really using it. And I did try and put a VASCATH for renal dialysis using the WED, and it was very difficult, I can say. And you couldn't do a nerve block looking at it. The radiology department here have a nice non-portable sonar, but obviously if you're in theater or in ICU, it's not going to help you. Then after trying to get either a different probe for the WED, a linear probe, I was unsuccessful. Trying to get the hospital to get a sonar more suitable for line insertion and blocks, I failed. So then I managed to buy second-hand portable ultrasound myself, and it was okay for inserting lines, but in terms of doing blocks, I and other people trying to use it had variable success. And the problem with it, one of the problems with it was the picture would often freeze, and you're in the middle of doing something and then you don't have a picture. Another issue we had was not having block needles to do local anesthetic blocks. And we generally, when we don't have block needle, we use spinal needles, and seeing the needle with this ultrasound was challenging. And so understandably, some of the registrars were reluctant to use it, and especially those that had rotated a bit in Windhoek and had access to very nice ultrasounds, they kind of said, no, this is just not up to the job. So that's my old ultrasound. The nice thing about it, though, is it doesn't have a cable. So in that sense, it's quite advanced, but it has limitations. So we did have people visiting Oshakati, and I encourage and always am willing to welcome visitors. It's a very nice part of the world. If you want to go on holiday and come and visit us, you are very welcome. And people would bring their own portable sonars, both people from Windhoek, local UNAM faculty, and people from overseas. And we were able to be very happy and do lots of blocks when they were here. Then we had Tim visit us December of last year, and I think he felt sorry for us. And so when he left his butterfly and donated it to us. And then this year in March, Tony Roach brought us another butterfly with an iPad mini. So now we are very privileged. So that's one of our butterflies. So we have one that we keep in ICU and one that we use mainly in theater. So sonar for what? So currently, as I've sort of alluded to, mainly it's used for line insertion and for doing local anesthetic blocks for anesthesia. Only anesthesia, obs and gynae who have their own sonar, by the way, are routinely using sonar in our hospital. We have medical officers. So a medical officer is a doctor in a department who's not in a training post. In radiology, who do formal sonars with a non-portable machine. They can be called to casualty to do a fast scan. They have no formal training, and they just have learned what they've learned on the job. And we have a very grave shortage of radiologists in the hospital. And there were times when we had, I think, one or none. We have a cardiologist in private who is down the road, and he can be consulted for echoes. And we were quite fortunate. We called him to ICU last weekend to come and do an echo on one of our patients. And I've got some of the pictures to show you later. But he doesn't come routinely to do an echo list. But the aim and the reason why I offered to do the talk, I thought by now I'd be a bit more experienced with POCUS, certainly on the ICU. But my challenge has been just lack of time to practice. So that's a bit my excuse. I was very inspired last month, Prof. Bugrara, on cardiac POCUS. And for those of you that haven't seen it, I would recommend to go and watch the YouTube video. Very inspiring. And we are now trying to do regular subcostal scans of patients, maybe once a day or once every second day in the ICU, having been encouraged by that talk. So we do some, we've run a course on difficult airway management. And on that course, we have a session where we teach people to identify landmarks for patients with predicted difficult airway using the ultrasound. I haven't actually done that on a patient, but I've taught it. We haven't used or explored its use for spinal anesthesia, especially in obstetrics, but that's something that we probably should be doing as well. So a couple of pictures. Can't give a POCUS talk without some pictures. So this is obviously a picture of the internal jugular vein, which is nice and big. This is the picture you always want to see when you put your ultrasound probe on someone's neck before putting in a central line, and a very nice small artery. So that's something that's, yeah, a good thing to see. So I don't know if you can notice at the bottom, there's a arrow through where the video thing is. So on one of our machines, it's not possible to do videos. I just have to do screenshots to get the pictures. This is not the picture you want to see when you're trying to put in an internal jugular vein cannula. There was also a POCUS talk on POCUS for vascular access. I unfortunately didn't have very good Wi-Fi the day of the talk, but it's on my to-do list to go and revise that lecture. Obviously, there are things you can do to try and get a better picture, which, yeah, I don't have time to go into today. That's just showing that we can, with our other butterfly, take videos, which is quite useful. So this is a picture taken in theater with our machine also that can take videos, just showing visualization of the needle. We do have a few block needles and some nice spread of local anesthetic. So this is, I think, the first patient that I tried to do a point of care ultrasound looking at someone's heart, or no, it's the second patient. So we have a patient in her 70s in ICU currently, who was referred to us from medicine with a supraventricular tachycardia and hypotension. And she came for potentially drug treatment and or shocking cardioversion. So that was my first attempt at trying to get a view, for a long axis 4-chamber view. And then I think this is a video, yeah. So with very minimal training and just listening to one lecture, it is possible to get a view. Interpreting the ejection fraction is another story. We, as I say, our cardiologist from private down the road came and assisted us and estimated her ejection fraction to be about 35%. Okay, so what kind of sonar should you have? Should it be a big one or a small one? Should it be portable or freestanding? I've seen in some of the videos people wheeling nice, quite probably high definition picture sonars to ICU patients. Should it be one probe or multiple probes? The advantage with the butterfly is you get different settings with one probe. But if they could have the butterfly without the lead, I think that would be great. So wireless or having to plug it in. And we can talk about the advantages and disadvantages of each. So what about other things that you might need if you are doing POCUS? So sterile sonar covers we don't have, although I got a donation of a few recently. Obviously, sterility is an issue, and how to clean probes and maintain probes is something that is important. Having block needles is an issue. We don't seem to be able to get them. Yeah. So whenever someone visits me in the north, I say, please put a few block needles if you can in your suitcase and leave them when you leave, which people have been doing. Plexus catheters, we don't. So I've used epidural catheters or specific plexus catheters a couple of times for amputations, where in Swansea, it was very popular with our vascular surgeons who did a lot of amputations, that you would use an epidural catheter and a toy needle, and they would directly feed the catheter into the plexus, and that can work very well. We have a shortage of availability of these sort of catheters, which limits our ability to do it. But it's something that people can do if you have access to a catheter and a needle system whereby the surgeon can place it. You don't need ultrasound. It's done under direct vision. Then infusions or boluses. So having some sort of catheter in place, you can even use a IV cannula and just connect that to an extension piece, which is what we've done before, because we don't have infusion sets. When I was in Swansea, there were available these elastomeric things that you inject 250 mils of local anesthetic, and it has a setting 5 or 8 or 10 mils an hour, and the patient just walks around with it. I don't know how much experience other people have with it, but it can work extremely well for 48 hours or so post-op. We unfortunately don't have those available in Namibia. So what about training? So I'm passionate about teaching and about training. So we are, I'm sure everyone, very grateful for this platform. It's been a great collaboration, and we look forward to what is to come. Having said that, sometimes you need a push to do things that you didn't do before. And sometimes you don't know what you don't know until you start doing it. We are obviously very grateful for people that have visited us in the north, both from Namibia, from Windhoek, and from overseas, and have been helping us on our journey with POCUS. But ideally, we want to develop a structured training program that can cover the main areas, so cardiac POCUS, different things in ICU, like looking at lungs, looking at abdomens, looking for free fluid, kidneys, etc. And then you need to be able to monitor what you are doing, preferably even record what you are doing. So one of our butterflies can record and one can't. And it was only when I was preparing for this lecture that I even realized that that was the case. So if you can record things, you can then get someone to review your recording and give you some coaching and feedback. In an ideal world, you'd have someone standing next to you, your shoulder, giving you that coaching and feedback. And as I say, even though my training has been limited, we do have access to a cardiologist who is happy to come on request and assist us. Yeah, so that one I've said. So what about accreditation? There was a Zoom meeting that I was in last year. I can't remember. I know it was a South African, whether it was an intensivist, anesthetist, or both, I can't remember. But what he said, and I asked him a question about accreditation, was that in South Africa, there's no formal accreditation for doing sonography, especially as an anesthetist or intensivist. In Namibia, there's no formal accreditation, not only for us as anesthetists or intensivists, but also for radiology. So that is an issue, and how we get around that is something we can discuss maybe in question time. So what other gadgets are there? I know for other things like teaching fiber optic intubation, we have intubating heads. We don't in Oshakati have any learning dummies. So the only learning really is I put it on myself, or like Tony said, I become the model, or I'm going to use it on patients. Is that ideal? We can debate that. I know with a butterfly, there are some settings where you can track your needle a bit more easily. And then in my reading, I see there are some AI things coming along where there are things called smart ultrasounds. I've never seen one. I wouldn't know what it looked like if I met it in the corridor. But I think the idea is that the ultrasound is able to help you as the practitioner. Maybe there can be a green light saying, yes, it's a good picture, or there can be some other way in which AI can assist you either to learn or interpret what you're doing. So maybe that's something we will get in the future. So I just want to sort of come towards the end with some top tips. So if you are new to POCUS, like us, don't give up. We started without an ultrasound, then we got a poor ultrasound, and now we have 2 butterflies. Start small, learn one technique. So obviously as an anesthetist, I learned to do CVC insertion with sonar. Then I learned to do some blocks. There are some blocks I'm better at than others. Start with something simple, get successful at it. So you pick the low-hanging fruit so that you don't get discouraged. And then find people to collaborate with. The fact that you're on this platform in this meeting means that there are people around. Grab someone near to you. And then make use of local colleagues. So as I say, we have this cardiologist who's willing to come every now and again and help us and teach us. And then collaborate with people from overseas that might be willing to come to your institution, come to your hospital, and do some teaching. So remove barriers. So if you have a sonar machine in the ultrasound or radiology department, you're not going to use it. If you have it in ICU and you're in theater, you're not going to use it very much. So we still have some occasions here where, despite having 2 butterflies, patients with having surgery where a block would be very nice, or na, as we say in the local slang, but some of the registrars, some of the medical officers, for various reasons, are not using the sonar and are not doing blocks. And we can talk about why that might be. We are trying here to cultivate a culture of learning, and it's been very encouraging, definitely in the ICU, where some of our medical officers are now not waiting for me to say, should we sonar a patient after the ward round, but are saying, hey, let's go and sonar some patients. Let's go to the ward and take our butterfly and do some sonaring, some focusing. That's a great thing to see, that the culture of learning is taking root here. And remember your successes. I vividly remember being asked by a registrar, can you come and help me to do a block? There's a young lady, I think she was 20. She had some sort of tumor on the arm and was having a above elbow amputation, quite a high amputation. I said, sure, I can come and assist with a block. I think, as usual, I was a bit busy in ICU. It took me a bit of time to get there. When I was going to theater, they were pushing a lady, a youngish lady, who was crying in pain from theater to the ward. And I thought to myself, is this, I wonder, the patient I was coming to assist with? And it turns out when I got to theater, it was. So what I did was I got the patient to come back from the ward. We put the patient back into theater, and we did a supraclavicular block. And I then admitted the patient to ICU for analgesia. being the head of ICU is quite useful sometimes. We did have a bed, and sometimes we do admit people who don't need critical care but need analgesia, and sometimes it's easier to do it in ICU. And she came to ICU not crying and pain-free. So sometimes you do a block and it doesn't work so well, you don't have the right equipment, or you're not 100% in terms of what you're doing. Don't concentrate on those patients, but concentrate on the ones that are successful, and I'm sure you will improve what you are doing. So what about the future? Some medical schools now are incorporating ultrasound into undergraduate medical curricula. So I spoke to colleagues from UNAM, the University of Namibia. It's not currently something that's been done, but it's something I'm going to start pushing for. I think our medical students should get formal training. And certainly with what I've told you in terms of how good the stethoscope is and how good the ultrasound is, I'm hoping that they won't argue against it. What is the cost of ultrasound versus a stethoscope? Obviously, it is more expensive. A butterfly, I think, costs about $3,000 US. So at some point, will universities be giving their medical students free sonars? Maybe, but we are not there yet. So back to our question that we started with, can we replace our stethoscopes with ultrasound in Oshakati, Namibia? Not yet, meaning maybe in the future. And a question that I ask my medical officers, mainly in ICU, what is the evidence? Does it improve outcome? So for the experts in the audience, is there evidence that POCUS improves outcome? I'm talking mortality. So happy to hear from the experts in the room. We have a lack of trainers. The trainers like me are not skilled yet. We are still in the beginning of our POCUS journey. We don't have any clear curriculum currently for what we should be training. We don't have any clear accreditation process. So we've got a way to go, but we don't want to reinvent the wheel. So those of you that have all these things, I'd be very pleased, happy, and looking forward to collaborate with you so I can maybe copy and paste some of what you're doing. And my kind of vision will be, I have trainees that are keen to learn. Maybe in a year's time, we can repeat this session and I'll get one of my or two of my trainees to basically, so that's where we were, this is where we are, and hopefully we'll be much further down the road. So I'm happy to take questions. Those are some of the references. I have them all as PDFs. If people don't have access to library facilities and PDFs of some of the articles, I'd be very, very happy to share with you. Thank you very much. Sorry, I probably went rambling on a bit long, but hopefully there's time for questions.
Chris, thank you so much for that wonderful lecture and for sharing with us your experience and really the barriers that you're facing in your institution, and just kind of more broadly. You asked a couple of questions at the end of your talk about point of care ultrasound and evidence regarding outcomes. So this is one of the biggest criticisms of point of care ultrasound is show me the evidence. It's really hard. It has been really hard to study in a randomized sort of a way the application of point of care ultrasound. Because it's hard to standardize and mortality outcomes already are very low. So it's hard to kind of see an N on mortality outcomes. Now, I will share with you, and I saw Dr. Lanspa earlier, but I think he must have signed off. Through the Society of Critical Care Medicine, we are putting together a new update on the use of critical care ultrasound, looking at specific questions and in particularly the outcomes in those questions. My hope is that that guideline document will be, our hope is that we will be able to push it out at the end of this academic year. So the beginning, maybe January of 2024. So I would be on the lookout for that, because that's going to answer, 5 very big questions for us as providers for critically ill and acutely ill patients in regards to outcomes, and what we call kind of patient important outcomes, and not just mortality, but also length of stay, days on the ventilator, all of the things, need for renal replacement therapy, for example, an organ dysfunction. So that will be one thing to look out for. I wish I could answer your question a little bit better, but just to say there is evidence out there in different areas, but for mortality itself, it's been really challenging. I think the one area where we have seen some evidence in recovery is for patients with cardiac arrest. The application of point of care ultrasound in cardiac arrest when it's applied appropriately. So when people have the appropriate training and they're not prolonging the time without chest compression. So it's incorporated, like Dr. Bugrara had showed in this last presentation, into ACLS within a 7 to 10 second time period. We're able to understand better what the etiology of the rest is for patients in pseudo PEA, and in that patient population, able to recover them more quickly. So stay tuned. That. I don't know if anyone else in the audience wants to comment on Chris's questions there, or if anyone else has other questions they would like to pose.
There is some question in the chat or a comment.
Okay, I see that here. I feel POCUS improve outcomes. It helps identify life-threatening conditions early. Vipa, I can't agree with you more. And that's just from my clinical practice. So I'll share with you all a story I will never forget. Years ago, I was faculty at Stanford, and when I was there, we had a patient who came up from the emergency department with documented urosepsis. So they thought urinary tract infection gone horribly wrong, now septic shock. And in the emergency department there, she got some fluids, initially responded like septic patients do, and then she kind of stopped responding. So they thought, oh, well, maybe she has developed septic shock and needs vasopressors. They started her on vasopressors, but at the time in the emergency department, the only vasopressor they had available in the Pyxis was dopamine. So they put her on dopamine, her heart rate increased like into the 120s or so, and she started becoming more hypotensive, more and more hypotensive. And then folks thought, well, maybe she's developing like cardiogenic shock. Maybe this is a septic cardiomyopathy. And they just started adding more and more inotropes, different vasopressors. And by the time she showed up to us in the ICU, she was on epinephrine, she was on dopamine, and she was on really high dose norepinephrine. So really high, 3 different. And the team was having discussions with her husband about withdrawing care, about we're at the end here, she's on multiple pressors, she's not doing well, we need to think about potentially making her comfortable. And I was the attending on in the morning to come, and the fellow that came on with me in the morning was cardiac trained, kind of like myself, and had a level of comfort doing ultrasound. So before I rolled in the morning, she put the ultrasound on the patient and noticed that the patient had what we call systolic anterior motion of her mitral valve. So basically what was happening was, because she was so tachycardic and she was in sepsis, her anterior leaflet of the mitral valve was flopping up and obstructing blood flow in systole to get out of the aorta and into her body, basically. So all the things that were being done were the absolute wrong things for that disease process. And we started changing our management, giving her fluids, taking her off of the inotropes, giving her just pure alpha, like just phenylephrine to give her blood pressure, to slow her heart rate down, increase her blood pressure. And by that afternoon, she was off of all vasopressors. The next morning, we extubated her. The next day, she was out of the ICU. And till I die, I will never forget that case, because we almost told this poor lady's husband that we couldn't do anything for her. And it was all kind of because we were blind, we would have been better to be that one-eyed person with some vision. So I agree with you. It's just hard to capture all of these experiences, these anecdotal experiences, and then go to the public and say, oh, we have evidence to support it improves mortality, when we've seen it improve mortality.
I think there was a hand up somewhere also.
Yes, I saw that. It says Department of Anesthesia. We saw your hand up. What questions did you have? Oh, I see something else. Okay. Any other questions that anyone has in the audience? We'd be happy to answer them. I just want to really quickly, while if folks are thinking of questions, it says, I would be careful about using length of stay for an endpoint. Yes, and that's definitely, it's the document is not out yet. So we're, but this is kind of for the way that we kind of sometimes look at these outcomes, or what matters to patients, and their amount of stay in an intensive care unit can be really important to them for a number of different reasons. But we're trying to evaluate all the different outcomes, and we have different panelists on the panel, patients being some of them actually on the panel. So, but I agree, there are lots of things that go into length of stay, so it's hard to pinpoint that this would be the one thing that would benefit that. Absolutely. I wanted to just, Chris, you had mentioned a couple of different things in your talk about, how to decrease barriers. And historically, some of the barriers really have been ultrasound equipment. You can't do something if you don't have the right equipment. The other barriers has been the teaching, but I would say that at least getting exposure to didactic teaching is becoming easier because of these kind of global platforms that we have, and these internet platforms. Where it becomes more challenging is the hands-on teaching. And that's where, having collaborations like this can be really helpful, where you can kind of organize a train the trainer sort of programs, where you have a handful of faculty who are really interested in becoming kind of experts or very facile with this, and having them kind of come up to speed, and then them going on to kind of disseminate locally the ability to do these sorts of scans. And there are all sorts of different societies that can provide that, but also our collaboration here. There's no reason why we can't help organize these sorts of things as we kind of build this collaboration, and that's one of our goals. And the other is to, like you said, pull on local resources. So if you have people who have a level of expertise, whether it's a cardiologist or a radiologist or whoever it may be, if you do this scan like you did, and you commit I always tell my trainees, commit, write it on a piece of paper. You don't have to be right. It doesn't have to go in the chart, but write it down for yourself to see. LV function is this, RV function is this. I see a pericardial effusion, or I don't. I see a pleural effusion, or I don't. Whatever the case may be. And then when that consultant or whoever helps you review, they're going to tell you what their interpretation is. And you're going to say, I thought it was this or that. Can you help explain to me why? Or another good opportunity is if ever someone does have a formal evaluation by one of these partners, you can do a bedside exam as well, and then compare your findings to the findings on the formal evaluation. And to be honest, that's how I learned when I was first learning how to do this. I would go to, and I know things are different, you know, here, but I would go to anyone who had a CT scan and say, hey, I have this ultrasound, can I come and scan you? And then I would compare my findings to what was found on the CT scan. So it was an opportunity to just like look everywhere, you know. So that's just some ideas there. I don't know if anyone else in the group has other ideas or thoughts or questions or wants to discuss barriers that they have, but we do have a couple more minutes before the end of the session here today.
I just wanted to make a plug quickly. Thank you, Chris, for the talk and for highlighting so many barriers to POCUS education. And to Sarah's point, you know, I want the group to look out for some messages from us in the future, in the coming months. We hope to do a survey of, you know, some of those barriers that Chris was talking about to see how best to optimize, you know, our collaboration and our network, and so that we can have everyone's skills to promote POCUS education everywhere. And in addition to the survey that we will do, we hope to actually use the answers to the survey to implement some educational, you know, things along the line, like Sarah was talking about, a train-the-trainer workshop globally, which some of our colleagues are already doing. Tony Roche and Dastin, they're in Namibia right now doing some POCUS education there. But yeah, welcome any questions.
Well, it doesn't look like we have any more questions today. Chris, are there any final thoughts you have before we sign off today?
Yeah, no, it's been an interesting thing just to kind of put my hand up and say I'll give the talk, because I don't feel like I'm very far along the journey. But just by doing that, I've learned things about our butterflies I didn't know. And it's sort of made me look a bit at some of the literature in terms of how poor the stethoscope really is. And it makes you, it's made me now want to go to some of the people in the university and say, like, they're visiting us in the north next week. Like, really, this is how poor a stethoscope is. Why aren't we teaching our medical students to use sonar? Because a lot of young people now are very savvy with technology, and I think they'll pick it up very quickly. Yeah. And they'll probably teach me, certainly be treating me at some point. So yeah, I mean, I'm completely sold now on POCUS, now that we have the kit to actually be doing it, and guys like you to collaborate with. As I say, invite me back in a year. I'm going to get some of my doctors to take the stage, and I'm going to be in the background, and let's see how far we've come in a year. Thank you very much.
Absolutely. Thank you so much, Chris. And thank you for everyone for joining here today. We look forward to seeing you next month. I want to tell you that Dr. Raj Nathwani, who is one of our trauma experts here at Harborview, which is a mecca for trauma, he's going to be talking about POCUS and trauma. And I just saw him present this talk at the Washington State Society for Anesthesiologists this past weekend. And it is an amazing talk. So please, 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 if you have a chance, watch it. I do not think you will be disappointed next month. It should be at the beginning of June, and we'll send out a reminder to you all. Thank you and have a great day wherever you are.